So the first specimen is coming from an 80-year-old female, and this is her CSF specimen. She had a history of lung adenocarcinoma and presented with hydrocephalus. So for the metastatic adenocarcinoma in the leptomeninges, if it demonstrates some like obstruction in the normal CSF floor, it will cause hydrocephalus. So in this situation, sometimes they would have the image to confirm whether they are a mass lesion in the CNS system, or they can do also a CSF tapping to demonstrate that metastatic cancer cell if there is no obvious mass lesion. Sometimes the metastasis is purely meninge based, so there was only the enhancement of the meninges but no mass lesion. And then sometimes they will also do the VP Chang drainage to release the obstruction. So in this CSF specimen, the most common like a presentation that we see for the metastatic adenocarcinoma is this type of single cells. So on low power, it might look relatively plain looking. Yeah. Okay. Okay. So on low power, it might look relatively plain looking. So it has a low NC ratio, plenty of the cytoplasm. The nucleus contour is very smooth and rounded, but you can appreciate the size compared to the adjacent red blood cells. The nucleus is very big. So this is actually a metastatic adenocarcinoma presenting as a single cell. And the single cell pattern is the most common pattern in the CSF metastasis. So sometimes they will also show binucleation, but the size of the nucleus were like very big. So this is the pap smear from the same patient. So in the pap smear, we start to see a little bit more aggregation. Sometimes not common in the CSF specimen, but here we see the aggregation, we see the intracytoplasmic vacuum. The cells is a little bit eccentric, and if you see the chromatin pattern, this kind of irregular and a small vesicular pattern, and with a very weird nucleoli. So this is positive for metastatic adenocarcinoma in the CSF specimen. So next is a CSF coming from a 19-year-old female, so very, very young. So in this specimen, we see a lot of cell which is not normal, because in the CSF, supposedly there is no cell. It should be like a cellular fluid specimen. But here we see a lot of cells. The cells has this increased NC ratio. I'm sorry, like a low NC ratio, abundant cytoplasm. And the shape of the cell is arranged in a epithelioid type of pattern. So abundant cytoplasm, rounded nuclear. They were single cells, but a lot of cells were in aggregates. So the nuclear does show a little bit pleomorphism. So this is relatively unusual in the CSF specimen that we most commonly see, which is just like a prior case, metastatic adenocarcinoma. So we start to see aggregates of epithelioid cells, but it doesn't particularly show a like epithelial arrangement. And she is very young, so that is also unusual. So when we go back to the clinical history, she actually had been diagnosed with glioblastoma, epithelioid glioblastoma with BRAF mutation. So BRAF mutation is like a most commonly in the so-called epithelioid form of GBM. So the morphology is very, very strange, but clinically they suspect the GBM already go inside the CSF floor. So these morphological pattern may be compatible with the epithelioid glioblastoma with CSF involvement. So glioma is usually, very rarely will go to the CSF fluid. So we almost never see this type of involvement at all. I think the nuclear feature for the histology section, it shows much more hyperchromasia. So for this specimen, it shows like a not so much hyperchromasia, but the cell, like the morphological pattern, do resemble the epithelioid GBM that I saw in the histology section. And the other thing is that if this is not glial cells, what cell type it is? It doesn't look very much like a histiocyte. It doesn't look very much like inflammatory cells. So it is likely to be the involvement of GBM. So this is, at least we should call this atypical or suspicious for the involvement of the epithelioid glioblastoma. So this is a very rare specimen that we see. So the next specimen is an ascites specimen coming from an 82-year-old female who came to our emergency department due to the abdominal fullness. So in the ER, they start to check the image, and they seeing there were a lot of ascites, so they do ascites tapping. On low power, we see like a monotonous population of mostly single but also like loosely cohesive cells. But the morphology here is just very uniform, very monotonous, which is a little bit uncommon than in the normal, like a reactive type of ascites specimen, that you would see different population of histiocyte, mesothelial cells, as well as the other inflammatory cells such as lymphocytes. But here we do see just like a hypercellularity and very monotonous appearance of these like a loosely cohesive or single cells. So this looks kind of suspicious. So we do not see an obvious second population like two-cell population, but when we go to higher power, we identify that a lot of these cells have cytoplasmic vacuole with like an oranginophilic color inside these. So these looks like intracytoplasmic mucin, and the cell showing this signaling cell feature. So if you take a look at these most obvious signaling cell and go to the adjacent cell, and they looks very similar. So this is most likely a metastatic signaling cell adenocarcinoma. In the abdominal fluid, the most common diagnosis is gastric cancer with peritoneal involvement. So this is her very first specimen in our ER department, and we diagnosed the patient with metastatic adenocarcinoma. And in the report, we will address that we see mostly Sjgren ring cells, so the clinician need to do subsequent endoscope examination to identify the primary lesion in the gastric cavity, in the gastric tract. And this is the very informative specimen, and we save a lot of time for the clinician to not to do other non-necessary evaluation. So this is the cell block. For the gastric cancer, we don't have a very lineage-specific IHC marker, but by morphology, this is just very typical Sjgren ring cell adenocarcinoma. So it's almost diagnostic for a gastric primary. So the next specimen, 66-year-old female, pleura effusion specimen. So on low power, we see like an inflammatory background, but we also see like these tight, like a bowl-shaped cellular aggregates. So these looks what we call cannonball pattern. So just on low power, we have these two cell population, the second population, and presented as the cannonball. So for the cannonball pattern, this is most common to be coming from the breast cancer. So the 66-year-old female indeed had a history of breast ductal carcinoma. So this is consistent. The morphologically, it's just consistent with the history of breast cancer. So this is positive for metastatic carcinoma and morphologically consistent with the patient's breast cancer. So the next specimen, 58-year-old female, pleura effusion again. On low power, we see a lot of aggregates of the cells. The aggregates show like a either bigger fragment, smaller like a aggregate, and it's more heterogeneous comparing to the cannonball cases that we just saw. So in the pleura effusion, if the specimen looks like this, with irregular like a glandular pattern, the most common primary is coming from the lung. So when we go to high power, we can identify typical morphological feature of adenocarcinoma, large nuclear, and vesicular chromatin prominent nuclear like polymorphism arranged in like a glandular pattern with cytoplasmic vacuolization. So this is consistent with the metastatic lung adenocarcinoma, and we see a big mitosis here, and the pattern is consistent with lung, and the patient do have a history of lung. So if you take a look of the cytomorphology, the chromatin pattern here, and you compare with the prior specimen breast cancer, for the breast ductal adenocarcinoma, usually the chromatin pattern is more like a squamoid type of pattern. Sometimes you will see more hyperchromasia, and sometimes the nuclear polymorphism, the atypia, the grade of atypia is not as high as the adenocarcinoma from lung. So usually for the lung cancer, it's more like a high-grade adenocarcinoma. So for the breast, sometimes it's smaller and more uniform, with a more squamoid type of feature. So morphologically, they looks different, and so you may have some like a different thoughts when you see the morphology. So then we move to a ascites specimen from a 66-year-old female. On low power, this is a very like an inflammatory specimen. So in the background, we see proteinaceous material admixed with a lot of inflammatory cells. So we see mostly lymphocyte, but also PMM, a lot of PMM as well. So in this type of specimen, we would expect it to see in the background there will be some reactive cells. They may look a little bit funny, but if you take a look around the cell population, like these all looks a little bit similar to each other, so most likely these atypical cells are just reactive cells. So when we screen this type of specimen, we usually will also start from a low power. So in this specimen, when you go from the low power, you start to see like a very scattered aggregates of cell and seems to be with a big nucleus just on this low power. And it is very scattered, very scattered. So sometimes it is not easy. So when we have a little bit like a screening on low power and we identify the area that we might want to go to high power, and so we go to high power, we have a very abnormal cell aggregates with a lot of cytoplasm. And you see this is a very big cell with a very big nucleoli, as big as the adjacent lymphocyte. And just right in these clusters, we see another much smaller cell also with a cherry red nuclei. And the cytoplasm, abundant vacuole, and it's very three-dimensional. So to the different level, we also see a much bigger cell with a much smaller cell. So we see gigantic nuclear polymorphism more than what we call 1 to 4. So this is diagnostic for a poorly differentiated adenocarcinoma. And these adenocarcinoma aggregates is very scattered in this specimen, so it is not easy to screen. But once you know how your enemy looks like, and then you start to see more, right? So again, this is a small aggregates and with a very three-dimensional appearance. So these focus, you have a very big cells with prominent nucleoli, and you move to a different level, another very big cell, prominent nucleoli. The shape of the nucleus is very funny and with a lot of indentation in the membrane. So these are positive for adenocarcinoma. And you just need to make a distinction with the adjacent reactive cell, such as this one and this one and this one. These all looks like reactive with a much smaller nucleus and nucleoli, and the chromatin pattern is also different. Here you see this is irregular and vesicle, and here is more delicate, very finely granular, evenly distributed chromatin pattern. So this is adenocarcinoma, and these are all reactive. So this is a relatively difficult specimen to screen, but you just need to make distinction of the cancer cell. It's much more ugly than the reactive cells. So the patient had a history of pancreatic cancer, and this is consistent with metastasis pancreatic cancer in the ascites specimen. So we move to the thyroid finite aspiration. This is coming from a 36-year-old female. So on low power, we don't see colloid. We only see very, very scant colloid. But we start to see aggregates of these cells. It doesn't show typical arrangement of follicular cells. So when we go to higher power, the cells show like a striking, crushing artifact. So this is what we call lymphocytic tingle. So, which means that these are aggregates of predominantly lymphocytes. So, in the background, we start to see this lymphocytic tingle. It looks more like a inflammatory process, and then we start to see the other aggregates looks like this. So if you don't have, if you have never seen these before, these might look a little bit weird because you see like an oval shape of the nucleus, and sometimes the nucleus also shows some vague intranuclear groove. But these are not follicular cells. And when you see these type of aggregates, you start to appreciate that this looks much syncytial. You don't really see the cell like a membrane, and you don't see the typical like a honeycombing type of arrangement. So this is actually a granuloma. So this is aggregates of granuloma that you can see. This is a multinucleated giant cells. These a little bit spindle-looking cells are all epithelioid histiocytes, so epithelioid cells. So this is an aggregate of granuloma. So we see one granuloma, and then we see more. So throughout the entire specimen, so we see this is also a multinucleated giant cells with some epithelial cells with more like a spindle-looking shape, but these are histiocytes. Again, this is also a nice like a Langerhans giant cell that is like a rosette type of arrangement of nucleus. And again, giant cell. So these are everywhere granuloma. So granuloma is kind of important, but it is not easy if you don't have any experience. So for these specimen, we see inflammation and mostly granulomatous inflammation. So here are a few cluster of giant cell. This is very prominent. So the most likely diagnosis for this case, histologically, it's a granulomatous thyroiditis. Clinically, this is a subacute decrevent thyroiditis. So this is an example of subacute thyroiditis in the final aspiration. So let's take a look of the direct smear. This is our loose stent. So again, in the background, very clean, without any colloid. And then you start to see this gigantic cell with multinucleation. So this is a multinucleated giant cells. And these spindle-looking cells are all histiocyte, epithelioid histiocyte. So this is a granuloma, a granulomatous inflammation. And the majority of the population are all these large, big multinuclear giant cells. And in this specimen, you start to see benign-looking follicular cells with honeycombing arrangement. So these are benign. And in the benign follicular cell fragments, it is not uncommon that you can see small, like a blue granulation, granular like a material in the cytoplasm. So this is very common in the benign follicular cells. So here again, another aggregate of benign-looking follicular cells. So pay attention to the uniformity of the nucleus, all small, rounded, arranged in a very uniform honeycombing architecture, and with relatively condensed chromatin pattern. So this is benign follicular cell. So we know that we are inside thyroid and with granulomatous inflammation. So this is granulomatous thyroiditis. So next, we move to the pap smear. So this is a 34-year-old female, so who had a history of low CO just at the beginning of this year. So this is a follow-up smear. So a young female, so we have a lot of superficial cells and the background is relatively clean. So we start to see like a very vague coilocity looking cells, but the contour of these halo is not very like obvious. The nuclear is not particularly big. The size is very similar to the adjacent benign looking intermediate cells. And the chromatin is not core, it's not hyperchromasia. So this is a very loose, like a very equivocal cells for precursor lesion. Here we see another one. So in young patient, HPV infection come and go. So they can have low CO, and then the immunity will clear the cells, and so it will become like virus-free after a couple months, sometimes within 1 or 2 years. So here we also start to see like a vague coilocity cells. The nuclear is not particularly big. The chromatin pattern is not particularly hyperchromatic. So this is again a very loose, like a sign, and it is in my criteria, it is not yet low CO. So for this case, we are calling these ascus. So this is what we call ascus. And so for the young female, it's very common. You have one smear low CO and another smear ascus, and it come and go, and then after a while, most of the patient will clear the HPV virus. So for the same patient, here we have some microorganism. So on low power, you start to see these large chunk of aggregates of squamous cells. And then you start to identify there are some string-like material going through this large chunk of squamous epithelium. So this is the pattern that we call kebab, like shish kebab. So we have Dr. Allah coming from Bahrain. That's their like a most famous dish. So everybody know what it is, right? So this is a typical shish kebab pattern that you have a straw and then are meat like overlapping with each other. So this is a candida infection. So we see the candida. So we must realize that these, how do you make distinction of a contamination versus a true like innate inflammation is that the candida, the hyphae, they will go inside the squamous cell because they need to like absorb some nutrition from the cells. So you can see this typical shish kebab pattern. Okay. So another microorganism. So from low power, you see that in the background it seems to be a lot of material, and the cell border is not very clear, and it seems to be a lot of like a granule or proteinaceous material in the background. And when you see the pattern like this, you need to think about the possibility of microorganism. So when we go to high power, so we've seen these, I think last week's or like 2 weeks ago, that we start to identify these much smaller shape, like with a pear-shaped material, and attaching to these squamous cells. And some of the squamous cell is actually like a broken just because these microorganisms attaching to it and try to store some nutrition from the cytoplasm. So this is a trichomonas infection. So this is also typical for trichomonas. When you see the microorganism, usually it is throughout the entire specimen, particularly for the trichomonas, because the microorganism proliferation is fast, and so you can see almost most of the specimen, you can see a lot of these trick cells here and there. And for the squamous epithelium, it is also not uncommon that you can see typical reactive change to the trichomona-like infection, that you will see a very small ring of halo around the mature squamous epithelium. So sometimes this type of halo change is very obvious on low power. So you will see the halo first, and then you find the microorganism, such as these and these. So this is very useful tip for our screener, that if you screen the case under 10x and you start to see a lot of these, like a very thin ring of halo around the nucleus of superficial cells, and then you can start to look for whether they have trichomona in the background. Okay, so this is a trichomona infection case. So that's for all today. Thank you.
Thank you, Doctor.